Good evening, everybody. It is a great pleasure for me to be participating in this Purple Day program, particularly when Dr. Schachter is the keynote speaker. I'm sure that we're in for a great lecture by Dr. Schachter. So it's a pleasure for me to be uh, talking about a certain area of epilepsy that is important for patients to be aware of. And that is the fact that uh, epilepsy is not only a condition where seizures are the only symptoms, but there are many patients with epilepsy that also have other type of issues that they have to contend with, one of which is the presence of psychiatric comorbidities, of which depression and anxiety are the most frequent ones. Now, when I talk about depression, I like to also talk about anxiety, because the presence of depressive and anxiety disorders in people with and without epilepsy often occur together. And it is important that patients, family members, and the treating physicians be able to recognize the presence of symptoms of depression, and when appropriate, the occurrence of symptoms of anxiety, because the treatment strategies have to target the two conditions when they occur. What are we talking about? Well, when it comes to symptoms of depression, how does a patient know that they're experiencing symptoms of depression? The first one and most frequent one is the presence of what we call anhedonia. Anhedonia is a term that pertains to difficulty finding pleasure in the typical activities that they usually would enjoy doing. The second cardinal symptom is the presence of sadness, a feeling of sadness that is quite pervasive throughout the day. So if an individual is feeling sad and is unable to enjoy things, that has to be a red flag for the possibility of a depressive disorder. Depressive disorders then can be associated with other symptoms that can be quite apparent to friends and families, such as a constant crying, feelings of hopelessness and helplessness, poor frustration tolerance and irritability, and feelings of guilt as well. Among the more serious symptoms that we worry about is when patients start having thoughts of wanting to be dead. Very often, these symptoms can come and go for a few days, but sometimes they can persist for up to weeks or even months, and they can have a significant impact in the daily activities of the patient. Symptoms of anxiety that patients need to be aware of are the presence of constant worrying. So when a person is constantly worrying about things that they usually don't worry about, or that there's no reason to worry about, that should be a red flag for the possibility of an anxiety disorder. And very often, together with the symptoms of worrying, can occur panic attacks, which are quite scary episodes during which the individual feels like something terrible is going to happen, a sensation of impending doom, with physical symptoms such as excessive sweating, palpitations, shortness of breath, and sometimes they feel like they lose feeling on one side of their body. These symptoms can go on for periods of 5 minutes or up to 20 minutes, and they can recur. Often when a person has panic attacks, they have difficulty uh, being alone or leaving the house. That's what we call agoraphobia. And it's not unusual that people with epilepsy who have seizures and are afraid of having a seizure in the street will develop symptoms of agoraphobia, meaning not wanting to leave the house for fear of having a seizure. Restlessness and pacing is very common as a symptom of anxiety, and being self-conscious about oneself is another one. So those are a list of the common symptoms of depression and anxiety that I think people need to be aware of and bring to the attention of their treating physician if they start experiencing them. Now let's talk about depression and anxiety episodes in people with epilepsy. What is it that we are identifying? Very often, patients will experience episodes of depression or anxiety independent of the occurrence of seizures. That's what we call interictal symptoms or episodes. At other times, these symptoms of depression or anxiety can be associated with the occurrence of the seizures. And this is what we call periictal. Ictal means seizures. And they can either precede the seizure by 1 to 3 days, during which they can experience these symptoms of sadness, irritability, anxiety, or they can be the expression of the actual seizure. It's what we call ictal or the aura. And the most frequent symptom of with a psychological component is ictal fear or ictal panic, which can mimic a panic attack in its presentation, except that the duration is very short, less than 45 seconds or 30 seconds. And these can precede the onset of the actual seizure. And then we are aware of symptoms that follow the occurrence of seizures. This is what we call postictal symptoms. And those typically occur not immediately after the seizures, but they occur a few hours to up to 2 or 3 days after the seizures. And they can present with symptoms of depression and anxiety that can last several hours or up to a few days. And then finally, these episodes of depression or anxiety can result from the treatment of the seizure disorder, either with the use of certain anti-seizure medications that can provoke those symptoms, or they can follow a surgical intervention for the seizure disorder, such as a temporal lobectomy. Now, it is important that people with epilepsy be aware that depression and anxiety disorders are frequent. And this is a table that shows the lifetime prevalence in a population of Canadian people. So that represents people with epilepsy in the general community. And as you can see, 1 out of every 3 people with epilepsy at some point in their life, and that's what lifetime prevalence denotes, will experience an episode of depression or anxiety. 1 out of every 4 people will experience at some point suicidal ideation. 1 out of every 5 people will experience a major depressive episode. And 1 out of every 4 people will experience an anxiety disorder. So this is a frequent occurrence that is of the essence to be recognized. Why should patients care? Well, first is because the presence of symptoms of depression and anxiety can increase the risk of mortality by facilitating the development of suicidal behavior. A person with epilepsy compared to the general population has twofold increased risk of committing suicide, but in the presence of depressive disorders, that risk increases 32-fold, and in the presence of anxiety disorders, it increases 12-fold. Person with epilepsy who is suffering from depression and or anxiety disorders that have not been treated will have a bigger problem tolerating the anti-epileptic medications, will experience more side effects from the anti-epileptic medications. And in fact, this is the result of an untreated depression or anxiety disorder. That's why it's important to recognize it. The impact of depression and anxiety in people with epilepsy on the quality of life is very, very significant. In fact, in people who suffer from epilepsy that is not responding to anti-seizure medications, the presence of depression or anxiety have a worse impact on the quality of life of people with epilepsy than the actual seizures. So treating the depression and or anxiety is important to improve the quality of life of people with epilepsy. And if you have a history of depression and anxiety, you are at increased risk of developing adverse events of the psychiatric type when exposed to certain anti-seizure medications or to certain type of surgical procedures for the treatment of epilepsy. And we'll talk about that in a few minutes. Now, we often think of depression or anxiety disorders as being a consequence of the epilepsy. But in fact, in many people, these conditions often will precede the onset of epilepsy by years or months. And it's important to recognize that patients with these kind of mood and anxiety disorders also will have a family psychiatric history, which can, when present, can facilitate or increase the likelihood that people will experience these mood or anxiety disorders after the onset of epilepsy. Often it is a recurrence of a previous mood or anxiety disorder that occurs after the onset of epilepsy. And when you have a prior history of these conditions and a family psychiatric history, the likelihood that the person with epilepsy will experience these conditions after the onset of epilepsy increases significantly. So this is what we call the psychiatric profile of the patient. Another important point that we have to keep in mind is that not only are people with epilepsy having an increased risk of developing depression, but people with depression have a 2 to 5-fold higher risk of developing epilepsy. So there is a bidirectional relationship between the two conditions. In other words, it's not unusual that a person who is suffering from depression or anxiety disorder will be on antidepressant medication for the treatment of their psychiatric condition, and the patient will develop a seizure, an epileptic seizure. It's not unusual for the emergency room physician to attribute the seizure to the antidepressant medication, when in fact that seizure would have occurred as part of the natural course of the psychiatric disorder because of this bidirectional relationship. And it is not necessary, and in fact, the antidepressant medication should not be discontinued. Now, depression can present with various clinical manifestations. The more serious one being major depressive disorders and bipolar disorders, which can be identical to that of people without epilepsy. Dysthymia is a condition that has a longer course, and very often, as I said, they occur together with comorbid anxiety disorders. or with personality disorders. Now, among the periictal episode, I just wanted to highlight the prevalence of these conditions. This is in a study with 100 consecutive people with epilepsy that had failed to respond to anti-seizure medications. 43% of them endorsed symptoms of depression after their seizures, and 13 had suicidal ideation. 45 endorsed symptoms of anxiety, and 7 endorsed psychotic symptoms. So this is not an unusual occurrence, particularly in people with poorly controlled epilepsy. And this table is just to show the duration that these symptoms can last, and the median duration is about 24 hours, with a range of 1 hour to 240 hours. Notice that the suicidal ideation seen in 13% of these people could last an average of a median duration of 24 hours. And it's the same thing for symptoms of anxiety, which can also last between 6 hours and 24 hours. Now, psychiatric episodes of depression and anxiety can be provoked by the treatments that we provide patients for the epilepsy. And this is the diagram of the patient psychiatric profile that we need to keep in mind, because it is people with a previous psychiatric history or a current psychiatric history who, when exposed to certain medications or surgery, the ones that are likely to develop psychiatric symptoms, what we call iatrogenic, that is the symptoms that are provoked by these treatment modalities. And therefore, it is important that your physician is aware of your previous psychiatric history and your family psychiatric history, in order for your clinician to anticipate whether you are at risk of developing these psychiatric symptoms. So, for example, the addition of certain anti-epileptic medications, such as that have negative properties, such as barbiturates, benzodiazepine, levetiracetam, topiramate, zonisamide, vigabatrin, tiagabine, and perampanel, can cause symptoms of depression and anxiety in people who have had a previous psychiatric history. On the other hand, some of the anti-epileptic medications are used by psychiatrists as mood stabilizing medication to prevent the recurrence of depression and anxiety episodes. And those are drugs that we consider as having positive properties, and include carbamazepine, valproic acid, or carbazepine, lamotrigine. And as far as anti-anxiety symptoms, gabapentin and pregabalin and benzodiazepine. If these drugs are discontinued in people with a previous history of depression or anxiety disorders, they can, the discontinuation of these medications can unmask those symptoms of depression, and the patient can start becoming symptomatic with those episodes of depression and anxiety. The treatment of depression and anxiety has to include medication, that's what we call pharmacotherapy, or counseling. The most effective type of counseling that we recommend today is called cognitive behavioral therapy. And often patients may benefit from the use of pharmacotherapy or cognitive behavior therapy. The aims of the pharmacologic treatment is to get rid of all the symptoms of depression and anxiety. Very often we may need to adjust the doses of the anti-epileptic medications and the antidepressant medications to get rid of, in order to avoid certain pharmacologic interactions between these group of drugs. The first choice in the antidepressant Group of drugs that we recommend is the drugs of the selective serotonin reuptake inhibitor class, which includes citalopram, escitalopram, and sertraline. If the patient continues to have symptoms after reaching maximal doses, then it is recommended that they undergo a trial with medication of the serotonin norepinephrine reuptake inhibitor family, which include venlafaxine or duloxetine. And the third choice is a drug of known as mirtazapine. It's always important to make sure that when we start antidepressant medications, the person is not suffering from a bipolar disorder, which is one of the type of mood disorders where the person has depression and manic or hypomanic episodes. This table is just to show that the same medications that we use for depression can be effective for the type of anxiety disorders that we often see in people with epilepsy. So the points to take home is that mood and anxiety disorders are relatively frequent in people with epilepsy. They yield serious and negative impact on the management of the seizure disorder and life of these patients at several levels, such as worse seizure control, worse tolerance of anti-epileptic medications, increased suicidal risk, worse quality of life, and they can be safely and effectively treated with antidepressant medications. Obviously, it's essential that patients bring to the attention of their treating physician the presence of these symptoms in order for them to be properly treated or referred to a mental health professional that can provide them the optimal treatment. Thank you very much for your attention.